Okay, you can hear. Okay, brilliant. Okay, this is the. Thank you. It's great to see people here. This is the first seminar in Augustine's court. And hope so far it's working.
Yeah.
I'm really pleased to have Marianna Karachaliou from Erasmus in Rotterdam, who's going to talk to us about the infectious origins of so-called non-communicable disease.
Thanks, George, and thanks for having me. Yeah, it's my favorite topic, so I will really also enjoy this seminar. So a little bit about my background, because it's not moving there.
We need to communicate.
Yeah. So it changed here, but not there.
Oh,
slides.
It did just change, I think, when you pressed it.
Okay.
Changed,
Yeah. So about me. So I'm a pediatrician. I was trained back in Greece. I'm Greek also. I come from Crete, from the wonderful island of Crete, but I have spent some time in Austria and Barcelona as well for studies. Do I need to do something? No. Yeah, and we have recently moved with a family to Netherlands. So this is the photo there with the family. So I was trained in pediatrics back in Greece. But I had a gap during my training because I had to switch from a small hospital to a bigger hospital. And then I was looking for a job, and we have a cohort in Greece called Rea Mother Child cohort. It's similar to ALSPAC. So I just found a job there, working as a field worker, collecting blood samples and doing the clinical examination of the children. And that really transformed all my trajectory, because I met those really nice people there, and I learned about these new things that they were doing and these new concepts and hypotheses that they were working on. So when I finished pediatrics, I just continued with my PhD and then a postdoc in IS Global, which is in Barcelona. So I just quitted clinical practice and being only in epidemiology right now. So yeah, in Barcelona, there's a really nice institute called IS Global. It's about global health. They do a lot of exposome research, and they also do some focus studies on infectious diseases. They are mainly working on malaria and HIV in low and middle income countries. But I did another project there. So I just created new data, new serological data on infections in 3 cohorts. So what I was doing in my PhD in Rea, we did it in 3 cohorts, but then COVID came up. So yeah, everything stopped. The lab wouldn't analyze our samples. They were only doing COVID, SARS-CoV-2 serology, and we also did COVID-19 research at that time. So that was the time that I switched from children to adults, actually. But that was nice, because in the end, COVID-19 came and transformed many things, but it transformed also our, the way we see infections, because it came out and then we realized that, infections may have long-term health effects, actually. And this is really now, long COVID is a good example now to illustrate that, we have an infection that is so common. Many of us can be infected with this pathogen, and some people will have long-term health effects because of this infection. So it was quite helpful, finally, in the end. So yeah, and then I was lucky because I got a Marie Curie, my Marie Curie project, postdoc project, was funded. So I went to Netherlands, where they lead the European Union Child Cohort Network, in which I will tell you, I'm trying to harmonize data on infections there. So this is where we are right now. And I'm also trying to create a network on this, again, specific topic, to understand in this field how to link early life infections with non-communicable diseases. So it's like a logarithmic spiral. It feels to me like that. Yeah, and I was really, I'm really happy because I have collaborated all these years with really nice people. Yeah. This is the echo. Yeah. yeah, it was Manolis Koyevinas here. You know, we have been working for many years now together on this topic, and Lida Hadji and many other people, basically from the REA cohort, and now with new cohorts that we're trying to collaborate. Okay, so yeah, so many of us have been working many years now to understand which are the causes of the non-communicable diseases, of the major non-communicable diseases, of so-called non-communicable diseases. And this is because these are the main causes of morbidity and mortality right now. And we have all these mental health problems emerging actually after the pandemic. And our research is largely focused, and also our prevention strategies, on these traditional risk factors like smoking, alcohol, unhealthy diet, physical inactivity, air pollution, and many others, the built environment and other environmental exposures. And this is okay, it's a good approach. But the only thing that we're missing from this picture are infections. Okay, and there's no reason for this. There has been a lot of research, but basically on cancer. So there are many studies looking whether infections lead to cancer. And we have also right now, we know human papillomavirus, and we have a vaccine for this to prevent cervical cancer. So we have examples that illustrate that, you know, infections may determine long-term health and disease and non-communicable disease, but there has been little done beyond cancer. So for the rest of the diseases of the non-communicable disease, we have done very few work on that. So I've said I have some examples here. So it's obviously human papillomavirus, for which we have a vaccine to prevent cervical cancer. We know a lot about Helicobacter pylori that can cause gastritis and gastric cancer. And we have antibiotics and therapy in general for that to eradicate the pathogen. We have hepatitis B virus, and we have a vaccine for this. And there are many more. We have streptococcus that is linked with rheumatic heart disease, and many more examples. I mean, in clinical practice, doctors, maybe some examples are more clear to them. But now it's emerging also in research. Now, the reason why there has not been, you know, a very good systematic approach to answer this question or to identify links between infections and NCDs, it's not that obvious. But if you go back in time and see, so here's a, here are the years. I'm just using the mouse so that people online can also see where I'm pointing. So here is the years, and here are the major funding calls we had that there have been on this specific topic, on understanding and linking early infections in general with non-communicable diseases. And these two calls have been out only recently. So that one was 2023, and this was some months ago. So there were only 2 dedicated calls on that. But if you go back in time and you see some reports and meetings, there was one very early in 2004 by the Institute of Medicine in the United States that was trying to create the idea that some infections may actually determine chronic disease. And this is a really nice report still, although it's a bit old, it's quite, you know, novel for me, even when I read it. So this is nice. And we also had, you know, after the pandemic and COVID, we also have some workshops organizing how infections and environment interact to cause chronic disease or to determine health and disease. And obviously with COVID, we have more examples that some infections, there's a lot of research actually on long COVID and other post-acute infectious syndromes. Okay, so it's like an umbrella term for the mid-term effects of acute infections. So and another thing I want to highlight here here you see a list of projects, or maybe you cannot see it because the picture is small, but here are the topics that this call the projects that this call funded. And it's very focused. There's a project on enterovirus with type 1 diabetes. There are 2 projects on EBV and multiple sclerosis, one on pneumonia and cardiovascular diseases, RSV and chronic lung disease. Then we have long COVID, 2 projects. And there is this ID dark matter project that we were discussing before, that it's more wide in terms of which infections they actually investigate, and they want to link with the non-communicable diseases. So, the projects that are still, although this was a call that was quite wide, they didn't say, focus on this specific NCD or focus on this specific pathogen. It was a quite wide call. The text was like that. The projects that they gathered were those that they were examining the specific associations, a specific pathogen with a specific disease. And this is okay, because we need this research, obviously, but it would be nice to see something more wide, wide exposure, wide outcome, to see what's happening. And the other thing is, in this exposome framework that it's coming out recently, the last decade, let's say, exposome is a framework that tries to understand all the factors that may determine health and disease, the totality of exposures in our lifetime of a human. Infections are not there. And none of the exposome projects that are funded right now in Europe, they have infections, none of them. And, it's a paradox because we are all exposed to infections. From our early life and continuously until we die, we are exposed repeatedly, or we carry infections in our body. And we don't know what's the effect of these pathogens in our body, actually. And many pathogens are globally important. So SARS-CoV-2 infected people around the world. It was not restricted to a specific region or area. So we have pathogens that are like BV or other pathogens, influenza, that infect people around the world. So infections are not in our research agenda right now in Europe and globally, I would say, with the exception of, infections with a pandemic potential like SARS-CoV-2 or Zika virus or HIV, for which we have studies. But, generally, what's the effect of a wide range of infections that we are infected? And many people think that it's because of the complexity that it's behind this. So this is also highlighted in this report I was telling you before, that was back in 2004, and it captures more of the complexity that this field has, so linking infections with non-communicable diseases. The one thing is, the pathogens. We have multiple exposures, and in the past we didn't have assays or tests to evaluate all these pathogens. We just had an ELISA to detect EBV, or we were screening for Helicobacter pylori. So we were very focused, and we had tests to screen for specific pathogens. So we couldn't go beyond those that we knew or we could detect. Now we can. We have new technologies that we can detect all the viruses that people are infected. It's the virus scan that we were discussing before. Or there are other technologies that you can detect antibodies to multiple pathogens that are validated, like the multiplex serology we have applied before. So the one thing is this, okay, we have multiple pathogens here. Now we have the technologies to detect all these multiple pathogens. And then we have multiple outcomes at the same time. So we see that infections may actually, so the pathogens can actually affect all these systems. We can see these associations in the literature, from the different studies that are around. So, they said that, this is complex. How can this be done? How can this be obvious? And here there are also another thing are the mechanisms, because we can have pathogen-specific mechanisms that are involved for a specific pathogen, let's say Helicobacter pylori, because Helicobacter induces, it's a bacterium of the stomach, and it can induce changes in microbiota, it can induce changes in micronutrient, in the absorption of macronutrients from the gut. It has also effect on our immune system, so it can induce also molecular mimicry phenomena, or we can have pathogen agnostic mechanisms, so that we can have different pathogens or the burden of the pathogens, or it could be EBV for one person or CMV to another person, let's say. So different pathogens in each person, but they will both act in the same way, in the same pathway, inflammation. So this is also, it used to be complex to consider, but now we have also assays and we have applied them in our cohorts to understand all these biological pathways. We have all these omics techniques to detect, from methylation from epigenetics to metabolome. So we can do more right now. And then the last two things are also really important. The one has to do with the duration of infection. How can you link an infection like influenza when you were 2 years old with having a chronic obstructive pulmonary disease when you are 60? That was an episode that occurred when you were 2 years old. How can you link that? So you need to consider that we have infections that, where we are repeatedly exposed and they are acute, self-limited, but what happens after we are infected with that pathogen? Is it still in our body or is it gone? So for example, for long COVID, the main hypothesis now that it's supported is that SARS-CoV-2 remains in the body. It could be in the gastrointestinal tract or in other sites in the body and in low levels and continues to stimulate the immune system. So it's not gone. So it could be also, there are also pathogens that establish a lifelong infection. So when we are infected with EBV, Epstein-Barr virus, the first time we are infected, then the virus persists in our body and we carry it for all our lives with us. So, these are also things that we need to understand and understand our exposure in this way. And then it's the timing of infection. So here we need a life course approach. So because, you could be infected with CMV, cytomegalovirus, when you are pregnant, when you are in your in utero, so congenitally, which has a very different effect compared to when you are infected when you are 2 years old or 4 years old. So it depends also when in your lifetime you get infected, and this probably determines your long-term health outcome. So, when we were looking at this as epidemiologists, which will be a good study design to study this? What would you think would be a good study design? I mean, you need a life course approach, you need repeated follow-ups, you need to have data on the exposure, on the outcome, and on the mechanisms. So, well, to me, and probably to many others, a good study design will be a longitudinal birth cohort. And and we need to start from early life, because this is a time that we are infected for first time. And first exposure is really important for for determining actually the health outcome of that infection. So we need to track the events. So we have now a link between EBV and multiple sclerosis, okay? So we know in EBV that it's very, everyone is infected. So if we get a blood sample from all of us right now and we do a serology, almost all of us will be positive, 95%. We will be positive. It's a pathogen that it's widely spread. And this very common pathogen is linked with a disease that it's not that common in the population, multiple sclerosis. How is it? So we need to go back and, EBV is a pathogen that we get infected when we are kids, so early in life. So we need to understand the whole history. And most studies are done in adults with EBV and multiple sclerosis. So they have adults so in the later part of this trajectory, of this course, I think the best would be to go back and track all the events. So from first exposure to EBV until the onset of multiple sclerosis or whatever health outcome. And you see this in this picture that was from a meta-analysis that was done 2006, so many years ago. You see the incidence rate of multiple sclerosis according to, so this is age, and according, it's stratified whether the infection was acquired late in life and resulted in infectious mononucleosis, because if you're infected with EBV in childhood, this will be an asymptomatic infection. If you are infected in adolescent years, it's more likely that you will experience symptoms and that you will present infectious mononucleosis. So if you got the EBV later in life and you develop infectious mononucleosis, the incidence rate is almost double or even more compared to whether you got EBV early in life and you didn't have symptoms, actually. And these are the people that never had EBV. Okay, so here you really see this. It's a very clear pattern. To me, it's also interesting to understand this difference. How is it that early EBV, that it's something that happens in so many people, also results in multiple sclerosis? So this is one reason. So early life is the time of first exposure to infections, and this is why we need to build the evidence from the longitudinal birth cohorts we have, and also because early life really has periods. It's a period of developmental plasticity. So it's the period that the structure and the function of organs is developing, and it's a period that it's quite vulnerable and sensitive to infectious exposures. And this is the DOHAT hypothesis, actually. This is a developmental origins of health and disease hypothesis that says that exposures that occur at early life stages can shape long-term trajectories of health and disease. And this DOHAT hypothesis actually was the reason, I think the main reason, that all these birth cohorts need some time to go there. Yeah. So these birth cohorts started in Europe. UK is doing great on this. You have ASPAC, PIP. I think this is
Southampton.
Yeah.
Study.
Netherlands has also nice studies, but Sweden and all the Scandinavian countries have all these big, quite registry-based studies. Spain has Zinman, and now they have also BISC that started during the pandemic, just before the pandemic. Generation 21, that is in Portugal, and in Greece we have REA cohort, that it's quite nice that we have from this area data. So quite big studies, and that's a very nice resource. And some years ago, I think it was 2022, that was the Life Cycle project. It was an EU-funded project that the aim was to harmonize the data across all these birth cohorts on different exposures and outcomes, so that you could run big studies on these birth cohort resources that you have in Europe. And the only data that they didn't harmonize was the data on infections. But these birth cohorts, they do have data on infections. So if you go back to each of these studies, they have data based on questionnaires. So these are the main sources of information that you can use to assess exposure to infections. So, and this line represents whether these are based on, with questionnaires, you can screen for presence of symptoms. So if someone had a flu or flu-like symptoms, or if someone had chickenpox, so you can screen through questionnaires, or with diaries, you can have people record their symptoms during specific periods. And there are also electronic health records that you can use. You can use the ICD-10 codes when you have access to for infectious diseases. This depends a lot on in which country you are, in which years, calendar years you are. There are also some registries that include diseases, infectious diseases with mandatory reporting. So SARS-CoV-2 was one of these. So probably in UK you have also data from registries who has been infected and when on SARS-CoV-2. But some countries are doing really well on that. Look at in Sweden, for example, they have this registry that it's called SMINET. It's for mandatory reporting of infectious diseases and combines information from the labs and from the clinics. And it started recording the population since 1997. It's in place since then. Some diseases started being mandatory reported later. I'm not sure which one right now, but you see, COVID, it's also here, and many others. Of course, these are not the full spectrum of an exposure to a pathogen. So you will have here, for example, you have Staphylococcus aureus, but you have also only the methicillin-resistant Staphylococcus aureus. Not every exposure, but this is also useful and has not really been used in this context. Only for COVID, actually, BAMSE cohort, which is based in Sweden, they have used it to see the association of air pollution with COVID-19 infection, and I think with long COVID as well. I'm not sure. So this is also, I think it's quite useful, and it covers the whole population, Sweden. So we can also take advantage of these resources with the good and bad things that these resources may have. So back to the sources of information. And for electronic health records, you have ICD-10 codes for specific infectious diseases. You have you can also use the treatments. So whether someone got a specific antibiotic. And you can also have information on vaccination, which is quite nice to have in a study, probably, especially if you want to monitor vaccine response. And then you have all these tests that are based on, biomarkers. You have microbiological tests. So in the cohorts, they usually have done this in nasal swabs, so to see whether you carry specific pathogens. And the one that is mostly useful, I would say, it's serology. So with serology, you detect antibodies that have been developed in response to an exposure to an infection. So in the EU child cohort network, in this network of birth cohorts, the data that have been harmonized on infections, it's only related to the upper and lower respiratory tract infections. So they used information based on mostly on questionnaires to define whether someone had the last year or the last 6 months, 6 to 12 months before, an upper respiratory or a lower respiratory tract infection. And this information goes from 6 months to 5 years of age. This is it, nothing more. This is useful. And you see that the peak age of upper and lower respiratory infection is at 1 year of age. So it's 63% of the kids up to 1 year of age, they had an upper respiratory, and 23% had a lower respiratory tract infection. But with serology, the nice thing is that, you detect, with serology, we can detect IgG-specific responses. So we have a specific response to EBV, positive or negative, or even you can have the antibody levels. And for the antibody levels, I'm still not sure what we would like to have. So when we detect antibody levels against vaccination, we would like to have high titers so that we will say that, this will be protecting you. But I'm not sure what's the best because immune system is a double-edged sword. So we will like to have intermediate antibody levels, high, low. Well, we wouldn't like to have seronegative if we are exposed, but what would we like to have? High or low or moderate? I'm not sure. Anyway, so with serology, we can actually define in principle, all infected people. So we could have all the iceberg, not just the tip of the iceberg that we will have with electronic health records, with questionnaires, or with diaries, because this will screen only for specific symptoms, and only those that present symptoms actually. So with serology, we will have all the information that we would like to, and it's also memory. So, you detect someone that it's infected at 7 years, you have samples at 7 years of age, and you identify that this person is seropositive. Yeah, it will happen from 0 to 7 years of age. So you have all this information, the cumulative history of exposure to people, to all these pathogens that you detect with serology. So this is interesting and complex at the same time, because if you don't combine repeated samples, then you cannot identify when someone has been infected to a specific pathogen, if you have only one sample. I mean, yeah, so back to the map. So in this map of birth cohorts, these are the ones, so these are the countries actually, or the areas that for which we can have information based on serology for some pathogens, not for all. Most cohorts, these are studies that the cohorts have done with their own resources for several purposes, to study specific research hypotheses. Most of the cohorts have information on EBV and CMV. And then the other herpes viruses, herpes simplex virus 1, 2, varicella. And then we have one parasite, Toxoplasma, Helicobacter pylori, and some cohorts, they also have on SARS-CoV-2. These are the main pathogens for which we have information. And most cohorts have data in childhood. Some also have during pregnancy, some maternal samples assessed. And now this is the picture, the table of, I can also share the presentation with you if you have interest to see. And we also have an Excel with all the, we also have by cohort and pathogen and by age, what information is available in which samples. But generally, what I want to show you here is that, most infections that have been assessed are viruses. It takes some time to go there. So we have CMV, EBV, herpes simplex virus 1, varicella herpes simplex virus 2, and those, and these are the other viruses that we have. We only have Helicobacter pylori and Toxoplasma. The only sexually transmitted infection that for which we have information is herpes simplex virus 2. It would be interesting, for example, to have on HPV or other sexually transmitted infections, after 16 years of age. I think it's interesting. I would like to highlight this pathogen, adenovirus 36. This is a pathogen that we included in our serology in REA, INMA, and BIP cohort that we did, and this is because adenovirus 36 is a pathogen that it's known in animal and human studies to induce obesity, but we have no data in children actually, in the child cohort. So this is why we did that. And now we are analyzing this data. It's a nice story to go back and see for adenovirus 36. There is quite a lot of literature from two main researchers. It's Richard Atkinson and another guy from India that I cannot pronounce his name, sorry, but I can share. And now we are finding also an association in REA, INMA, and BIP. So the status, both of the mother in pregnancy and of the child later on, it's associated with obesity at later time points, but it's negatively associated with lipid metabolism, with the lipoproteins and with the liver enzymes. So this is a paradox, but this is in accordance with the studies in animals. So let's see. So if you plan to do serology, try to include adenovirus 36. I'm curious to see what will happen with that pathogen. And then another thing to highlight in this table is that, here we have the ages. we lack data at this time point, so at early ages, so from 1 to 3 years of age. We don't go earlier, so we don't go to do serology at 6 or 4 months of age, because all the antibodies that we will detect at that time point will be from the mother, because IgG is actually the only immune response of the mother that can be transferred from the mother to the child. So we don't go that back, because these responses will be because of the mother's immune response, not of the child. So this will not be useful. So we lack of data at this time point. Actually, we have some data, but not a lot at this time point that will be quite useful. But this is, I understand, because there are restrictions to collecting blood at these ages. But yeah, there are options like the dried blood spots to collect at these ages, and there are also some new machines, but very expensive, that you attach here and you can have a blood drawn very with no pain and at home for the kids. So this would be also nice to perform in the future. And then we don't have data. It's moving very slow. And then we don't have data here after 16 years of age in the cohort. So we don't have a lot of information of what is happening in adolescent years, which is really interesting, because in early life, the status and your responses will be determined by what happens in your family, in your environment, in contact with your parents and with your siblings. Then it's school age, and then kids and adolescents are independent. The way they get infections is totally different compared to earlier ages. So that will be also nice to see in the future. And here it's an overview of the disease associations that have been examined so far in different cohorts. Most, there are cohorts that they're doing a case control mostly in DNBC and MOBA. They have done case control studies to see whether maternal status to CMV or to other pathogens is associated with neurodevelopmental delays or with certain congenital defects. So they're quite focused, the research hypothesis that each cohort is examining. It will be nice, though, to use this data to examine, CMV has been examined in relation to respiratory health in generation R, but in another cohort, it has been examined in relation to autism. You can do both things in both cohorts, actually, or we can do all together. Yeah, so this is the advantage of doing all this in the UTL cohort network, because all these data are harmonized. And on other also core characteristics like socioeconomic status, siblings, smoking, whatever we think that will be interesting in this disease exposure outcome association. So we can harmonize data on infections for the children and for the mothers during pregnancy. And we can use to examine all these associations. And of course, here we can integrate, the interplay of environment with infections, because in this network, many cohorts have common or harmonized data on environmental exposures through all these exposome projects. And we can also integrate data on the biological pathways, all the omics data that we have and more. And something that I always think interesting would be do in the future, probably in the network, will be to harmonize data for the mothers. So we will have the pregnancy status, so informing on the status of the mother at some point, and probably this will not change. So we don't expect new CMV or EBV infections in adulthood, or many, let's say. So, and then see whether this status or how the immune status during pregnancy, which is a very specific period for the immune system, it's like a challenge pregnancy for the mother and the immune system of the mother, how this will be associated with health outcomes for the mother. So, for example, we have done in Marianna and BIB and also some other studies, I think Generation R and another one, we have shown an association between Helicobacter pylori and preeclampsia. So it would be nice to see whether Helicobacter pylori status of the mother is associated also with cardiometabolic or cardiovascular disease for the mothers, if there are data collected for the mothers at later ages. So if someone wants to write a grant to harmonize data on health outcomes for the mother, it would be interesting. Now, besides all these associations with the health outcomes, I think one thing that we are really missing is the descriptive epidemiology. So here has changed, but not yet here. But we will wait. So we need to understand who is infected, when in time, and where in place. So who, when, and where, the basic things for describing not moving. Yeah, so here. So going back to the study that we did in REA in MindBeep, so we had samples in pregnancy, 4 years, 6 years, 11 years of age, and we see differences between cohorts, so between countries actually. And we also see differences between ethnicities, especially for BEEP, that it's a cohort that has Western and non-Western ethnicity in a high proportion. And we see also differences in time. So when someone has been infected. So these are data. This is information from repeated data, from repeated samples from the children until the age of 12. And let's take EBV. So EBV, if you look the status at 12 years of age, it's 90% of the kids are infected by that age. But when the infection occurs, you will only have if you use the repeated data for these children. So you can identify that 70% have been infected up to 4 years of age, and then another 20% until 15% until 9 years of age, and then the rest 5% until 12 years of age. But the seroprevalence in mothers. So if we were in the past, the EBV seroprevalence at 12 years of age of 90%, it will appear a bit low. You will expect more. And their mothers have like 96% of seroprevalence. So you still have kids that are not infected to EBV up to the age of 12. So this is also interesting to know, the non-exposed, actually. And if we have samples at later time points, we can identify whether they will be infected or not. So whether they will reach the seroprevalence of their mothers of the previous generation. And why age of infection is important? Because the time that someone has been infected determines, obviously, we know this for many infectious diseases, it determines the acute infectious syndrome that they have. And this is very clear for RSV, and it drives also the vaccination program for RSV. We see very high morbidity in when infection occurs at early life and early years, and then starts to rise at later life stages. So now we have vaccination for the adults for RSV, and we have in pregnancy for the mothers, so that they can transfer their antibodies to RSV to the kids that they are born, so they are protected here. So this drives also vaccination programs. But this pattern that we see for RSV, it's obvious for many other infectious diseases. Yeah, so go back and look on this paper by Glean. So this demonstrates a J-shaped association between age of infection and severity of the acute infectious disease for many of the pathogens that they're globally important or significant. I think dengue is the only pathogen that doesn't follow this model, and it would be nice to see whether what we see for acute infectious disease, so the association of age with the severity of the acute infectious disease, also replicate in relation to the long-term health effect of the infection. So I'm just showing here the graph for COVID-19 mortality and long COVID. So this is the association between age and the severity of the disease. We know that the older you are, the more likely that you will have a more severe disease and you will die for COVID. And there are differences between male and females, which is also interesting. And then for long COVID, you see also that long COVID is more likely to occur, young adults actually. then this drops, but maybe this is driven also by the high mortality that we see here from the acute infectious syndrome. I'm not sure, maybe. But it will be nice to see whether this, and we know for long COVID, you know, because the exposure occurred for all of us after 2020. So here the age of presentation of long COVID is actually the age of first exposure to the pathogen. So it's a nice example to see whether this association, this shape of the association between age of infection and severity of the acute infectious disease also replicate when we look to the age of infection and to the long-term health effect of the infection. And I'm always trying to think, what is age of infection? What does it show to us? So age of exposure is obviously important because it might coincide with the specific window of development of a functional or a structure of a specific organ or system. So this follows the Dohat hypothesis we have been discussing before, but it could also reflect duration of exposure. If you are exposed to EBV when you are 2 years of age, you know, you have more years of exposure to this specific pathogen, or less year if you are exposed later on. So, and this goes for the pathogens that we get infected with and they persist in our body, but it can also apply to pathogens for which we are reinfected, so like influenza. So will you have your first influenza when you are when you are during your first year of life or later? So it will apply both on here, and you see here, so these are data again from this project in the 3 cohorts that we have repeated samples and that we could define when exposure occurred. So for almost all antibody responses at age 12, the higher antibody levels we detect among those that they are exposed early in life. Earlier in life leads to higher antibody responses, which was weird to me in the beginning, because I would expect that, you know, the more recent I will have an infection, I would expect that my antibody response will be higher, but it's not like that. The earlier you're exposed, the higher your antibody responses turns to be. This is the pattern. And then the other important thing to think about is the route of transmission, because maybe this has a meaning from where you are exposed to, which is the route that you had the infection. So for CMV, if your mother is seropositive, you can be exposed when if you are delivered, if there's a vaginal delivery with exposure to vaginal secretions, or you can be exposed as well through breast milk, because CMV is transmitted through breast milk to the child, or through other sources, either from your mother, through contaminated other biological fluids, or from other people in the household or in the childcare. And we also see some evidence that the route of transmission that the age of infection has some information on the route of transmission when we look on the herpes simplex virus 1 and 2. So now we know that when there is a lack of oral herpes simplex virus 1 infection in childhood, this leads to a higher risk of genital herpes simplex virus 1, or even a more severe genital herpes simplex virus 2. So this is important. So when you have lacked exposure to herpes simplex virus 1 through oral transmission, then you are more likely to get it through sexual transmission. So this is so later in life. So this is later in life, this is earlier in life. So this is actually the serology that you will get will be positive, but you will not know whether that was from a genital transmission or from oral transmission. And another important factor in relation to the age of infection is maternal status, because, you know, we have shown that when a mother is seropositive, it's more likely that kids will get an infection at an early age. And this is an interesting topic that some people have highlighted before, and I'm also trying to follow, because when you're infected early in life, so the first 12 months of life, the exposure occurs in the presence of maternal antibodies. So the exposure occurs at the optimal conditions. because you have maternal antibodies ready to help you fight the infection. And probably this is the best way to immunize yourself to this specific pathogen or to control this pathogen in your body. Yeah, and I'm closing with 2 more slides. So what we did in the REA, I'm going back to REA because we've done all these disease associations. So this was my PhD actually. So we tested to all these pathogens in German Cancer Research Center in a validated multiplex serology. We did it in maternal samples and children's samples at the age of 4, and we didn't have an a priori hypothesis. We just said, okay, let's screen all these pathogens with all these outcomes. And you see the associations that come out. So these are the cognition and behavioral outcomes, asthma and other allergic diseases, eczema and rhinitis, and these were obesity indices. And we also looked not just each pathogen with the outcome, we also grouped them. So we grouped whether someone has been exposed to a higher herpes virus burden, higher polyomavirus burden, and then Helicobacter pylori was independent. And these are the associations we had. But I'm not showing to discuss the specific associations, but it was interesting to see, a pathogen here. Let's say respiratory polyomaviruses. We have Karolinska and Washington polyomavirus. So Karolinska was protective for eczema, but was detrimental for asthma. But we have to understand that these associations and how they exist. Yes, I think we need to follow, my view is to follow this approach. And because time is running, I'm just going to give an example of some associations that we can more specifically examine in this EU child cohort network, that we have the harmonized data on the outcomes, and we will harmonize data on infections, so we can do cross-context comparisons because we have data from different cohorts at different study sites. We have pregnancy and child samples also. We have in one cohort, generation 21, we have also paternal samples, and they have also evaluated the status of Helicobacter pylori in pregnancy. So this could be a paternal negative control for the exposure during pregnancy. And we can also potentially run Mendelian randomization. We're doing now with a master student, but we have no results. But yeah. Yeah, so summarizing just this, just we need to work together. So when you start, you think that when I wrote the Marie Curie, I thought, it's very easy and straightforward to do all the things, but if we work together, we will be able to, to tackle all these challenges and reach the end, and probably a good end. Yeah, thanks.
Thanks so much. There's so much fascinating material, and also thank you for being the guinea pig at the first seminar, the first day in this building. You had a small PowerPoint. You had to stand in front of the laptop. Okay. Next time in the seminar, it'll get slightly better. You come. Okay. So, questions, comments?
Thank you so much for the presentation. I wanted to ask, is there much work looking into, I guess, the aggressiveness of treatments in reducing the pathogen burden or the rate of clearance, and how that might affect the outcomes?
So all these pathogens that we are detecting, we don't have really treatments. We could only have for varicella, that, for example, in Greece, we vaccinate for varicella, but not in the rest of the countries. Or I think they have introduced also in Germany. UK, I think you don't vaccinate for varicella. Yeah. But this doesn't affect, obviously, these results because these are old data. Antibiotics will be relative. We haven't seen an association with Helicobacter pylori status, though. But yeah, I think it's really interesting to also integrate in all the treatments or preventive measures that we have for all these infections, so antibiotics or vaccination events.
Well, antivirals and COVID, I suppose.
Yeah, also, yeah.
Next.
It's brilliant stuff. It's super exciting, and the life course. The life course stuff is really, really elegant. But I had a question about some of these slightly later infections, and it's from experience of microbiome research. When we had the thought, let's look at the host genetic contribution to the microbiome. Let's think about putting that in a causal framework. We can start asking questions about causality. It's really, really hard. And we find that of the very few signals that you get for host relationships, genetic relationships to a microbiome, almost all of them are driven by disease or are not real. And so there's something to do with the person and then its effect on the microbiome or the bugs within it. And I just wondered whether that bears out for pathogens as well. And whether, so having the life course thing in some of these early signals is really clear. The pathogen comes first, the disease comes later. But I mean, the example there of long COVID later, for example, is it actually that there's a habitus which is having an effect on these infections that drives an association? Or is the other way around? And what do you see?
So for infections, it's a bit tricky because you have to see what's happening in your population right now. So EBV, it's universal. I mean, everyone is exposed. So the pathogen is there. So what determines your susceptibility to the pathogen? It's actually how spread is the virus in the community, nothing else. It doesn't have to do with you. It was the same with SARS-CoV-2. What determined our exposure? The fact that we have controls or not, nothing else. So it doesn't have to do with us. It's how spread is the pathogen in the community. But what could determine will be how we respond to this pathogen. So, and what we detect and what we use here is the antibody responses. So it's a humoral immunity here, actually. So this could be, this could be the case. So when we are looking at associations with the antibody responses to a specific pathogen, this could be different for pathogens, because we have some examples with malaria that, there is also some genetic associations with having the infection or not. But I'm not an expert on genetics, actually. And seeing this, I'm not sure if I answered your question.
Well, it's really just whether not just the genetics, but just that the associations that you see in cross-section, there's these nice ideas that infection might be relevant for these other non-communicables, or it's whether some of those non-communicables are actually generating conditions which have an influence on either the likelihood of infection if there is any variation, or the response to the infection if it is there. So the other way around.
So it could be a bidirectional association for some. So for example, with obesity, we know that obesity is a risk factor for having influenza or having a severe influenza or maybe an effect, a very severe influenza infection. So it could be a bidirectional association. And also we know that, like adenovirus 36, as I said, it's a pathogen that can induce obesity. So you have a circle there. So or a syndemic, let's say. So we have obesity happening and we have a pathogen in a specific population. The one contributes to the other. How can we break the circle? And we also have pathogens that, they affect your growth. So actually what was common in early years was that infections actually result in underweight status, not in obesity or overweight status. So, and underweight status is also, you're more susceptible to infections as well for many reasons. So both can happen. Just for an example that I can't think easily. But we could discuss more or think about it more, all of us,
There's a couple of questions online. Has much been done on causal inference in this area apart from the examples you mentioned at the end?
Not a lot, I would say. Or a systematic approach to that. Very specific, on specific pathogen disease associations, I would say.
And lastly, knowing that long COVID affects people mostly in their productive age, is there any strategy on this?
I'm not aware. We're not doing research on long COVID, and we see something really paradoxic. So you see that. So this graph shows here that it's posted there in the chat that the higher risk of severe COVID is among men, but long COVID is more common in women. So how does this happen? So we're trying to understand this, and we're publishing a paper on this now.
I think there's also the fact that what's called long COVID in these older people is completely different to what's long COVID in these 30, 40-year-olds, 30-year-olds. Because like Michael Rosen, who's in his mid-70s and is a very famous child author of kids' books in the UK, he's like a pin-up, and he became a sort of activist in long COVID. I mean, he was in an intensive care. He infarcted half a kidney, lost a chunk of his heart muscle. He has not got the long COVID that, it's a very completely different thing. He's got the physical consequences of having had a very serious intensive care experience where he lost organ mass. And that is not the long COVID that you see in the
No.
It's a completely different thing, and it's just a category error, and to treat it as it's not the same thing.
Yeah, and actually now we don't have good definitions for long COVID. I mean, they are all based on present. So that the recent definition that NASM has proposed is having any symptom, at least one, from any organ for at least 3 months. But this is somehow okay because we have to be inclusive with long COVID.
Yeah.
Because there was a lot of skepticism about who has long COVID and whether this is like a psychological condition or not. So some people remained underdiagnosed actually because of that. So yeah.
So well, thank you again. We want to hear follow up on this in a couple of years' time when we're all spring down. Thank you so much. Thank you.
Thanks. Liam?
Yes.
Okay, lovely.
On the day.
Welcome. Thank you also. It was really nice.
Yeah.